This patient was referred to me for endodontic retreatment of tooth number 15. According to the patient, this root canal was done 5 to 6 years ago. Recently, she started to have some symptoms, some pain to chewing, to biting down on the tooth. And then suddenly, she also noticed a swelling right above the tooth. So that prompted her to go see her dentist, and her dentist told her that the root canal's gone bad, the root canal's failed and needs to be redone. And patient was referred to us. So take a look here. Crown, of course, build up, previous root canal. Look how short these fills are. But take a look here. There is no periapical radiolucency. No periapical radiolucency. Tooth was tender to percussion and palpation. There was a sinus tract. Let me show you. So right here. Okay. So patient says the swelling was much larger, and her dentist put her on antibiotics and the swelling went down, but I can see the remnant of it right there. Okay, so again, you can see there is no periapical radiolucency. All right, no periapical radiolucency really here. Why did this root canal fail then? What is that sinus tract draining? Where is the periapical radiolucency? All right, and here comes what I always tell you, to never, ever, ever, ever rely on just one angulation PA, just one PA to make your diagnosis. Never, ever, ever, ever do that. And here's why. And here it is. Take a look here. So the dentist who did the root canal perforated right out the distal buccal. So was probably looking for this distal buccal and perforated right out of this distal buccal, and then I think found the distal buccal and was kind of confused, had no idea what the heck he was doing, didn't even realize, maybe he did, that he perforated, and he actually obturated the perforation with gutta-percha sealer. So that's why this root canal has failed. That's why there's a sinus tract there. There was buccal parulus. So if you had just relied on one x-ray, you would have missed all of this. You would have recommended the root canal to be redone, just like what her dentist told her, recommended, and that's why the dentist referred her to us, because he probably or she just relied on one x-ray. But only if he followed me just like you guys and listened to me just like you guys, pay attention to these stories and take a mental note just like you guys, then he or she would have taken a couple of more angulation PAs and notice that. And well, sometimes you take x-rays, but if you don't know how to read them, then you can also miss. So if you take you can take 100 x-rays. If you don't realize that this is a perforation, then you miss it. But here it is. Needs to be. So I discuss options with the patient. This tooth has a very guarded to poor prognosis, and let the patient know, and decision was made. She's gonna extract it. All right, so look at this beauty. This root canal, or this patient, was referred to me for endodontic retreatment of tooth number 3. According to the patient, the root canal was done over 10 years ago in Lebanon. My beloved, beautiful Lebanon. And patient doesn't have any symptoms whatsoever. Zero, none. No symptoms at all. So take a look here. So you can see a crown here. What happened to the distal buccal canal? What the heck is this? Well, that's a broken file, of course, right? That's a broken file right there. And it looks like it's right into the sinus. And it's been there, stayed there for years, over 10 years. No periapical radiolucencies, none. No periapical radiolucencies whatsoever. Let me show you a different angulation so you can appreciate what's going on here. That's the distal buccal canal, right? The distal buccal canal looks like the dentist was looking for it and almost perforated to the outside. See, that's the distal buccal canal right there. And he had drilled this way and actually maybe perhaps even started to instrument, not knowing that he wasn't even in the canal, and went ahead and obturated with gutta percha. But the canal is right here. All right, so no symptoms, no issues whatsoever with this tooth. And again, as you can see, that's the broken file, right out of the palatal root. Right out of the palatal root. No problems whatsoever, no issues whatsoever. And perhaps maybe there's a missed MB2 also, again. Lucky. Lucky dentist, lucky patient. Or lucky dentist and even luckier patient. All right, so we're not going to do anything about this tooth. We're just going to leave it alone. Leave it alone. We'll just make it worse if we decide to do. I mean, there's no reason. I have no justification to recommend endodontic retreatment on this tooth. Patient has no symptoms and there are no periapical radiolucencies despite all of these mishaps. All right, so told the patient, leave it alone. Don't even touch it. Leave it alone. Let the tooth be the way it is, and you know. This tooth probably will be in her mouth for the rest of her life. All right. This patient was referred to me for endodontic treatment of tooth number 18. Another reason why multiple angulation PAs are important. Patient says 2 weeks ago, her face was all swollen up. She went and saw her dentist, and her dentist told her that her tooth number 18, which is the lower left second molar, was abscessed and needed the root canal. Patient was put on antibiotics and referred to us. Today, patient says she took the antibiotics and swelling went away. So she's here for root canal of tooth number 18. Multiple angulation PAs. Again, another reason why you should take multiple angulation PAs. Another reason that you should not trust another clinician's diagnosis. Okay? Don't trust another clinician's diagnosis. Do your own homework. Do your own diagnosis, okay? So take a look here. As I always tell you, we never ever rely on one angulation PA to make a diagnosis. So as the patient is telling me this, I'm looking at the x-ray and I'm like, well, if you had a facial swelling, I'm thinking to myself, if she had a facial swelling, wouldn't there be a periapical radiolucency? I mean, it could be a acute apical abscess, but very likely not. If the patient has a facial swelling, very likely there is a periapical radiolucency. So you need to look for that. Very rarely you find a facial swelling with no periapical radiolucency, and that's called an acute apical abscess. Okay, let's look at another angulation PA. Okay, again. Look, it's fine. Number 18 is fine. Number 19 is fine. That's normal bone anatomy there. So that's not a periapical radiolucency. All right, let's look at the next PA. Okay, I'm looking at this PA, and I'm like, okay, fine. What is going on here? That's tooth number 20. What's going on here? So I told my assistant, I said, go ahead and take a PA of this. Usually my assistants are very good. They read x-rays better than most clinicians. But I think today she was kind of off and she missed this. So I said, okay, take a couple of more PAs of tooth number 20. And she did. And look at this. Lo and behold. Tooth number 18 was never an issue, so her dentist misdiagnosed. But of course, as I said, we never ever rely on another dentist and other clinicians' diagnosis to recommend treatment. We do our own. All right, so it was not tooth number 18. It was tooth number 20. Look at that huge periapical lucency there. And also look at that inflammatory resorption going on right there. All right, so patient couldn't even believe it because she was sold by the dentist that tooth number 18 was the abscess tooth. So I did some patient education, and that's very important also, educating your patients, and talk to her about the infection here, the resorption, inflammatory resorption there, went over her options. We can try the root canal, no promise or guarantees, only time will tell. Root canal could fail, then you would have to pull the tooth. Not only because of the infection, but also because of the inflammatory resorption. Or the other option is to go ahead and extract the tooth. And patient said she wanted to try to see if tooth could be saved. All right, so it was not tooth number 18. It was tooth number 20. Look at that huge periapical lucency there. And also look at that inflammatory resorption going on right there. All right, so patient couldn't even believe it because she was sold by the dentist that tooth number 18 was the abscess tooth. So I did some patient education, and that's very important also, educating your patients, and talk to her about the infection here, the resorption, inflammatory resorption there, went over her options. We can try the root canal, no promise or guarantees, only time will tell. Root canal could fail, then you would have to pull the tooth. Not only because of the infection, but also because of the inflammatory resorption. Or the other option is to go ahead and extract the tooth. And patient said she wanted to try to see if tooth could be saved. All right, so let's talk about this case now. This patient was referred to me for consultation regarding tooth number 30. All right. According to the patient, the root canal was done many years ago. Recently, he noticed a swelling on the lingual side of the tooth. So he went and saw his dentist. His dentist put him on antibiotics and referred him to us. So take a look here. Again, never, ever, ever, ever rely on just one PA, one angulation PA to make a diagnosis. Never, ever, ever, ever. I don't know how else I can put this into your heads. This needs to be tattooed to some of your foreheads so you don't forget, because usually when you DM me, need my help, you send me one PA. And that one PA that you send me is terrible quality. I can't even read it. So it's such a bad quality PA. Anyways, never ever rely on just one PA. All right, so crown here, of course. Previous root canal, as you can see. Metal post here, as you can see. Percussion, slightly tender. Palpation within normal limits. Let me show you clinically what we found clinically. All right, so here it is. That's the tooth, and this is the sinus tract right on the lingual aspect of the tooth. And look where this sinus tract is. Look what it is. Look how high up it is, how high up coronally it is. All right. So I want you to pay attention to all of this. Look where it is, the location, how mesial it is, and how coronal it is. All right. Now let's go back to the PA. Never, ever, ever, ever rely on just one angulation PA. In this PA, you can see the Coke bottle shaping of the mesial canals there. So that tells me that this dentist very likely used Gates, Glidden, and drill. So really, really, really thinned out the canals here, the root. Look at this angulation here, and looking at this angulation here, you can see where the problem is. Right there. And this corresponds to where the sinus tract is, the location of the sinus tract. So what do you think this is? The Coke bottle shape? Preparation of the canals, the thinning of the canals, the location of the sinus tract, and where this periapical lucency is. This is all pointing to what? All of this is pointing to a root fracture, a vertical root fracture there. Because of the thinning of the dentin. When you use Gates-Glidden drills, you just remove so much dentin, and over time, that thin wall, remaining wall, just cracks, fractures. As you can see, that no periapical lucencies. But the problem is right there. You saw the sinus tract on the lingual. I probed the tooth, actually. Probed 3 to 5 millimeters all around. But all of that combined, all the information that you gather, multiple angulation PAs, the location of the sinus tract, the fact that there are no periapical lucencies, where the lucency is so mesially corresponding to the sun, all of that, you need to put all of that together. What would have happened if I had missed all of this? What would have happened? I would have recommended redoing the root canal. I would have redone the root canal. Well, charged the patient, right? Went through the crown here. Put the patient through so much pain and suffering. Removed the post. Redid the root canal. Then patient paid me for redoing the root canal. Then patient would go back to their dentist and have the crown replaced. All of that on a tooth with a hopeless prognosis, because I wasn't paying attention to, or I wasn't aware, I didn't have the knowledge to gather information and then come up with the proper diagnosis. All of that, the patient would have suffered financially, and also, of course. Another example why you should never, ever, ever rely on just one radiograph to make a diagnosis. And your diagnosis, the armamentarium, should be multiple. History taking from the patient, detailed history taking from the patient. Okay? Multiple angulation PAs. Percussion test, palpation test, mobility test, vitality test, probing test, biting, chewing test. Then you put everything together. You analyze everything together, and then you come up with a good, solid diagnosis. Okay, so take a look here. This root canal, according to the patient, was done over 5 years ago. Patient got a crown, then tooth started to hurt. Then root canal was done through the crown, and now patient says when she presses with her finger above the tooth, it hurts. And of course, we know why. Look at that large periapical lucency there. All right. So if I just rely on one angulation PA and want to make a diagnosis, my diagnosis will be wrong, and the patient will suffer, not only financially, but also emotionally and physically. Okay. And of course, the treatment or retreatment in this case won't work. Take a look here. So tooth was percussion and palpation very tender. Mobility was slight, but still within normal limits. Okay, so now take a look at different angulation PA, and look at this angulation PA now. What's going on here? Right there, that lucency there. And of course, you can see the large periapical lucency here, but there's definitely something going on here that you could not see on this x-ray. So never ever, again, never ever ever rely on just one angulation PA to make a diagnosis. And you can see that here now. Now let's go ahead and probe it. Okay. So let's see. We're getting on this side here, and I'm getting about 9 millimeters here now. There it goes. You can go even deeper, but I'm not going to push it. There you go. 9 millimeters. Thank you. All right, so you saw the probing and the probing depth, and now we can make a good diagnosis. We save this patient lots of money and pain and suffering. This patient, if we misdiagnosed and recommended redoing the root canal here, the patient would have paid for redoing the root canal. The patient would have likely had to pay me to redo the root canal, pay the dentist to get a new build-up and crown, and of course the root canal retreatment. The retreatment would have failed because we had misdiagnosed. So, but right now, just now, we saved this patient tons of money. We told the patient this tooth has a hopeless prognosis. Don't spend a penny on it because of the fact that the root is fractured. Contact your dentist today and have your dentist arrange for the extraction of tooth number 12, and hopefully patient will go with a dental implant here. So all the money that she was going to waste on having the root canal redone, tooth rebuilt and recrowned, all that money now, because we diagnosed properly, she will spend all that money towards extraction and getting a dental implant there. All right, so that's what you need to do. You can't just make a diagnosis just so casually. It involves a lot of different steps.